Evolution is the engine that powers biologic diversity. Through natural selection, individuals with characteristics that improve the odds of survival will be more likely to have offspring, and those offspring are likely to share those characteristics. In time, over many generations, natural selection allows species to adapt to their ecological niche. And if they cannot successfully adapt, they do not survive. This process has been going on for many millions of years. But evolution is slow. Species cannot quickly change their genetic makeup. About 65 million years ago, huge changes in the climate and food supply killed off all of the dominant land and sea creatures on Earth. The dinosaurs could not adapt to a quickly changing environment, and they became extinct. Those rapid changes, it's thought, were probably brought about by a large meteorite striking the Earth. Evolution wasn't fast enough to keep up with the resulting environmental upheaval, at least not for the dinosaurs. Humans, modern humans, probably appeared on Earth 2 million years ago. About 10,000 years ago, which is really just a blink of an eye comparatively, agriculture started to develop. And only maybe 50 years ago did the ecology of our lifestyle undergo its most recent monumental change, maybe as big as the meteorite hitting the Earth. That change has been so profound and so fast that the slow pace of evolution, again, can't possibly keep up. If we're going to continue to thrive as a species, we'll have to find other ways to adapt. What was the big change? Let's start with today's Grand Rounds patient first. Charles, he goes by Chaz, is a 16-year-old young man who has come into our pediatric clinic today with the chief complaint of headache. The next part of the encounter is learning more of the history, or the HPI, the history of the present illness. This is a traditional part of every medical encounter, typically following the chief complaint. The HPI is a story, the story of the complaint or concern that the patient has. It's usually best to let patients start talking on their own. Let them tell you in their own words what's been going on without a lot of prompting or interrupting. You may have to direct the story a little bit, ask some questions to clarify things, but remember, you won't learn anything if you do the talking. The patient needs a chance to tell you what's been going on. This isn't just to collect information. It also helps establish what's called the therapeutic alliance. Listening itself is powerful medicine. Chaz says he's been getting headaches for a long time, maybe a year or more, but they've gotten worse lately, and they're happening almost every day now. He's been late to school many days, and he knows that's affecting his grades, so he's here to see if we can help. We ask a few questions now to elicit more information from Chaz. It's often a good idea to focus on the main symptom first and find out things like, what exactly does it feel like? When did it begin? And is it continuous or intermittent? How long does it last? And what sorts of things make it better or worse? Sometimes the timing helps. Is this a morning or evening symptom? I also like to ask, if the patient hasn't already told me, how does the symptom affect your life? Is it a big deal, or is it something you can live with? And is the symptom getting better, getting worse, or just staying the same? This is what we learn about these headaches. They're getting worse, though not dramatically much worse, just more frequent. They started, he thinks, a few summers ago and almost always happen in the morning, or at least Chaz first notices them when he wakes up. They feel, this is the word he uses, tense along the sides of his head. Over-the-counter pain medicines like acetaminophen do help the pain feel better. Chaz says the pain is never terrible, but it's hard to get to school some mornings. We then ask about other symptoms. Is anything else going on? Chaz says no, he's otherwise okay. There have been no fevers, no sinus congestion, no allergy symptoms, no vomiting. Other than the headaches, Chaz says he has no problems. Let's think a second before we proceed. A few words about headaches. They're very common, and most headaches in children and adults are not caused by anything that's going to lead to serious problems. Now, that doesn't mean the headaches themselves aren't a problem. Headaches can cause a lot of misery and missed school and work. But most headaches are what are called primary headaches. These include migraine and tension headaches. When first evaluating a patient with headache, the most important initial decision is whether this is an ordinary primary headache, or could this be a rare secondary headache, a headache with a specific medical cause that needs to be identified and treated. Secondary headaches, in other words, can be the ones that really make us worry. A brain tumor or a bleed in the brain is probably the most ominous. These are quite rare, but these are the headaches you do not want to miss. We'd also want to be sensitive to headaches perhaps caused by medications or a sinus infection or from concussions or trauma. All of these headaches need specific therapy. To figure out whether a headache is primary or secondary, the clues are almost always found in the history and the physical examination. The most important single clue is the pattern of the headaches. Headaches that are intermittent, occurring every once in a while, separated by many days, free of symptoms, are very unlikely to be of any urgent medical cause. Headaches that are constant, especially headaches that are progressive or worsening from day to day, and headaches accompanied by abnormalities on the physical exam, those are the headaches we never want to miss. So far, I don't think Chaz's history neatly fits into either category. They had been long-term intermittent headaches, but they're getting worse. They've gotten more frequent, though it's not really clear that they're progressing much from day to day. Sometimes the history does leave us in a bit of a gray zone. Let's see what clues we find on the physical examination. Chaz looks comfortable and well. His weight is 260 pounds and height 6 foot 2 inches tall. The measured blood pressure is 140/100. His pulse is 88 and respiratory rate 16 breaths per minute. Okay, that blood pressure, it pops out, doesn't it? A normal adult BP is 120/80. So Chaz is 140/100. That is way high. Could an elevated blood pressure itself cause a headache? Typically, no, unless it's really super high and rising quickly. You flip backwards through the electronic chart. Chaz has been seen once or twice a year for the last few years at our clinic, and he's never had an elevated blood pressure before. You look at the cuff sitting there on the table, and you realize what the problem could have been. Your nurse used an ordinary blood pressure cuff, the one labeled for adults. But Chaz, he is a big guy. That cuff is way too small for him. Vital signs are crucial, and it's important to measure them carefully and accurately. One pitfall with blood pressure measurement is that if the cuff is too small, the bladder, that's the part that squeezes, won't completely encircle the arm. So you end up having to pump it up even higher to affect arterial blood flow, which results in a falsely elevated blood pressure reading. The first thing to do when faced with an abnormal looking result, a blood pressure or anything else, is to make sure the measurement was done correctly. You find a bigger cuff, the one that is labeled adult thigh. But it doesn't matter what the label says. All that matters is that it fits all the way around his arm correctly. You repeat the blood pressure measurement, and it's still high at 128/84, though not as high as it was. And this mildly elevated BP is not a cause of headaches. We'll go through the rest of the physical exam now. HEENT, that stands for head, ears, eyes, nose, and throat. That's normal. Chaz is not congested and has no findings to suggest allergies. Also, when you look way in the back of his eyes with your ophthalmoscope, you can see there is no elevated pressure back there. That's an important part of a headache examination. If there were changes in the back of the eye to suggest increased pressure in the brain, we'd be much more worried about things like a tumor Now, that pressure elevation isn't always easy to spot, but it's good practice to always look for it. The general exam of Chaz's lungs, heart, and belly is okay. We also do a detailed neurologic exam, looking for deficits or problems with strength or reflexes or coordination. Again, we want to make sure that there's no hint of a problem in the brain, and all of that is normal. Okay, mild hypertension, otherwise a normal exam, right? No, there is something important here, something that's become so common that we might even be tempted to overlook it. But it's our job to do the best for our patients, which means we've got to think about Chaz's weight. Perhaps it's a separate issue, or is Chaz's weight somehow contributing to these headaches he's been having? Although it's imperfect, most research and clinical measurements of obesity rely on what's called the body mass index, or BMI. This is calculated as the weight divided by the height squared in metric units. But really, most of us just rely on our electronic records to give us that number. The BMI is useful because it incorporates both weight and height. Obviously, taller people are supposed to be heavier, so you can't just judge obesity looking at the weight alone. But it doesn't differentiate lean body mass or muscle from fat or adipose tissue. Someone who spends a lot of time at the gym with solid muscles and very little body fat may actually have a high BMI, even in the obese range, though they're not overweight and have excellent health. Still, the BMI is simple and we're used to it, and it can easily be tracked over time. Another measurement that's a more reliable indicator of overweight and a better predictor of health problems from overweight is the abdominal girth. That's a simple thing to measure with a tape measure, but it hasn't caught on. People seem to be self-conscious about someone wrapping a tape measure around their midsection. In adults, a BMI from 18 to 25 is considered a healthy weight. From 25 to 30 is overweight, and above 30, obese. Chaz, who is 16, has a calculated BMI of 33. At that age, we can use those adult norms. He is obese. Of even more concern, you can see in your EMR that his BMI has been trending up and up for years. If he doesn't make some changes, it looks like that BMI is really going to end up very high. Higher BMIs lead to more complications of obesity and more severe complications. And higher BMIs become more and more resistant to therapy and lifestyle changes that can reverse the problem. The sooner we can get some changes in place, the more likely they are to help Chaz get to a healthy weight. First, though, we'd better concentrate on these headaches, since that was what Chaz was worried about. Or, if there's a connection between the headaches and the weight, maybe we can take some steps to address both today. Let's think about the common complications or the medical problems that are associated with obesity. Many of them coexist under the name the metabolic syndrome, which includes high blood pressure, insulin resistance, and abnormal cholesterol and other lipids. And all of these can contribute to strokes and heart disease. People with the metabolic syndrome are also at high risk for developing type 2 or so-called adult onset diabetes, and that can occur even in children. That is serious business and can dramatically diminish the quality of life. But typically, headache is not a symptom of these problems. Another common complication of obesity is called non-alcoholic fatty liver disease, or NAFL, which is pronounced NAFL. In past decades, one of the most common causes of chronic liver disease had been alcohol abuse, but that's being overtaken by a complication of obesity, fatty accumulation in the liver that can lead to liver failure, leading to death or requiring a transplantation. We even see abnormal liver tests in overweight teenagers. This is not just something seen in adults. But again, NAFL doesn't particularly cause headaches as a main symptom. There are many orthopedic complications of obesity, including problems with the feet and hips that cause pain and interfere with exercise. This can make it harder to get someone to be more active. And many people who are overweight have decreased exercise tolerance to begin with. They tire out simply from carrying too much weight. It is a bad cycle, with pain and decreased ability to exercise leading to more weight gain. Many teens and adults with obesity also suffer from psychological problems, including depression, anxiety, bullying, and social isolation, and those can cause headaches. When we talk with Chaz, he said he has not been feeling down or hopeless, and he's enjoying spending time with friends. Just those few brief questions make it unlikely that he has major depression. There's a specific obesity complication that can definitely cause headaches, but we've already ruled that out on our physical exam. People with obesity can develop what's called pseudotumor cerebri. That's a peculiar sounding thing, a pseudotumor. This is not common, but it's not so rare either. In pseudotumor, there is increased pressure within the cranium, in the brain, but it's not caused by a physical tumor. What's happening is that the normal flow of fluid around the brain is interrupted and the fluid pressure goes up. Pseudotumor can occur with obesity, and it's also associated with endocrine disorders and certain medications. Or sometimes it occurs with no known cause. On the physical exam, when we looked at the back of the eyes with the ophthalmoscope, we saw no changes to indicate pressure back there. So pseudotumor is very unlikely. Obesity can also interfere with sleep, and that's actually another negative cycle that makes treatment of obesity difficult. It turns out that insufficient sleep or insufficient quality of sleep leads to hormonal changes that make it more difficult to reach a healthy weight. And insufficient sleep is also associated with high blood pressure and metabolic changes that contribute to diabetes. Many of the complications of obesity are intertwined, and they reinforce and contribute to each other. One of the mechanisms of poor sleep in obesity is obstructive sleep apnea, where the airway closes off during sleep. The patient will wake up, at least partially, then gasp and breathe again. And this can happen many times an hour. And each time it happens, it interferes with normal, restful sleep. People with sleep apnea often report daytime tiredness. There can also be irritability, poor school or work performance, and increased risk of car accidents. Spouses or housemates of people with sleep apnea can also have very disrupted sleep from the snoring. And sometimes they're the ones dragging the patient in to see the doctor. And another symptom of obstructive apnea can be headaches, especially headaches in the morning when you wake up. You ask Chaz, do you snore or have trouble sleeping well at night? His mom interrupts. She says, boy, does he snore. I can hear him right through the wall. Chaz says he knows he wakes up sometimes with a feeling that he couldn't catch his breath, and he doesn't feel rested in the morning, and he falls asleep sometimes in school. Children, even teenagers, should not fall asleep in school. That's not normal, no matter what you might see in movies about teenagers. Chaz says he tries to go to sleep by 11 and doesn't wake up until 7, but really, he always feels kind of tired. This history is very suggestive of sleep apnea, and sleep apnea could certainly explain his morning headaches. You explain this to the family. First, that the history and the exam don't make it look like anything is an emergency here, but that you can tell these headaches are a real problem, especially since they're getting worse and interfering with school. You think that it sounds like Chaz has obstructive sleep apnea, which can cause headaches just like these. In the short run, there are just a couple of things Chaz can try that might help some. Trying to sleep on his side may result in less apnea than sleeping on his back. Chaz says he already figured that out, that if he ends up on his back, he wakes up. An old-fashioned trick that might help is sewing a tennis ball into the back of his shirts, the shirts he sleeps in, making it uncomfortable to sleep on his back. There's also some evidence that steroid nose sprays can help at least some people with sleep apnea by shrinking the nasal and adenoid tissues. We'd also like to schedule Chaz for a polysomnogram, also called a sleep study, to really see what's going on at night. This kind of a study can show if there are periods of obstructive apnea by showing that his chest wall keeps moving even when he's not able to breathe in and out. Though from the history alone, it does sound like sleep apnea is very likely. More definitive therapy for obstructive sleep apnea is more difficult and invasive. In younger children, and in many teens like Chaz, surgical removal of the tonsils and adenoids helps. There's also a non-surgical option using a tight-fitting mask at night to provide what's called continuous positive airway pressure, or CPAP. This kind of device provides extra pressure, like blowing up a balloon, into the mouth and nose to stent the airway open even during sleep. Many people with sleep apnea and their spouses love their CPAP devices. They can finally get a good night's sleep, often after many years or decades of chronic exhaustion. But other people can't seem to put up with wearing that mask all night. We make arrangements for the sleep study and for Chaz to follow up with an ENT specialist after the study is done. We also ask Chaz to make a follow-up appointment with us in a few weeks to see if some of our simpler ideas work. We'll also need to follow up on his mild hypertension, which can improve if he loses weight, and consider a laboratory evaluation for insulin resistance to check his lipid profile and to rule out fatty liver disease. But really, we still need to address the bigger picture here, which is obesity. If Chaz can lose some weight and keep it off, we know his sleep apnea can improve, and he'll lessen his risks of other obesity complications too. We'd like to suggest some ways for him to do that, but at the same time, we don't want to drive Chaz away or make him feel that we're pointing fingers at him or his family. One good way to address topics like obesity is through a process called motivational interviewing. This is a method to both get information from a patient, but also to engage someone's own motivation as an impetus to drive changes in behavior. It's a way of thinking about problems that starts really with the patient. What are you worried about? Have you thought about making any changes? Or are you ready to change? These techniques were developed in the 1980s to address problem drinking, but they apply very well to encouraging lifestyle changes to address obesity, or to stay on top of diabetes or asthma, or really any other chronic problem that has a behavioral component. We start by saying to Chaz that sleep apnea is a common problem in people who are overweight. Do you have any concerns about your weight, Chaz? If he says no, it's going to be difficult to get him to make any changes. You'd concentrate first on perhaps outlining the problem or why you see it is a problem, even if Chaz does not. Today, Chaz says, yeah, of course. I know I weigh too much. Then you reflect back and empathize. I hear you saying you're concerned about this too. Then you ask if Chaz thinks now is a good time to think about making some changes to make some progress on the problem. Again, if the answer is no, we won't then go on to pursue specific recommendations. We'd back off and talk about how perhaps Chaz might change his mind about that later, and that we'd like to help with that when the time is right. But if Chaz is ready now, we can ask him if he's thought of something that he might be able to do. Chaz says he was thinking he might be able to drink less soda. We reflect that back and agree that that would be a positive change and try to nail down some details. It's not realistic to expect all soda to stop, but maybe come up with some numbers. If he's drinking a soda every day, then how about deciding to have 2 sodas a week? Ask Chaz if he thinks that would be a change he could make. Now, this might seem like a slow process, this motivational interviewing, but working it into a conversation about health habits isn't really difficult and doesn't have to take a lot of time. The idea is to hopefully come up with just a small number of definite changes that the patient thinks he can do, not a huge, vague sort of list. Agreeing that, just for instance, I'm going to eat healthier is much less likely to be successful than a small, incremental step that's easy to think about, like I'm not going to buy popcorn at the movies every weekend. Though it can start with a few simple ideas, the management of obesity in children is difficult. There are family and genetic influences. The biggest risk factor for childhood obesity is parental obesity, though it's not entirely clear whether this is mediated by genetics or by a shared environment and by eating and activity styles. It is nearly impossible to help a child fight obesity on their own. You have to include the family, and sometimes that's difficult to get all parties involved and motivated to change. Though parents often ask about medical causes of obesity, these are really rare. Parents have sometimes heard that hormonal problems like hypothyroidism can cause obesity, but in fact, the pattern of obesity is very different in these kinds of disorders. If a person is overweight because of hormonal issues, they'll be short and overweight. They stop growing taller. But if a person is overweight because of basically absorbing more food energy than they need, they'll be tall and obese, like Chaz. A simple history, physical exam, and rarely a few basic blood tests will rule out any specific treatable medical cause for obesity. The main cause of overweight, stated simply, is a condition of energy imbalance. If people eat more food than they need to meet their own energy requirements, the extra food energy will be stored, mainly as fat. More calories in, or fewer calories spent exercising, and the net energy equation will leave excess calories to lead to overweight. But it's more complicated than that. Obesity is not only about individual people making individual decisions. There are societal and neighborhood influences, like where is the nearest store with affordable fruits and vegetables? Is it safe to ride a bike to school? Where is the closest playground? Family decisions, too, are important, like how often do we eat out, or what size portions are we used to eating? Sometimes the behaviors associated with food are just as important as the foods themselves. We know people who eat quickly tend to eat more, as do people who eat while they're doing something else, like watching television. We also eat more when we're worried or stressed. Sometimes early influences can have a significant influence on weight control throughout a person's life. We know that women who are overweight or diabetic have children with a much higher lifetime risk of obesity, perhaps in part because of activation or deactivation of certain genes. Toddlers learn lifelong habits about food choices long before many parents start to think about the health consequences of potential obesity. The foundations of healthy versus unhealthy habits start very young. There's also a layer of dense biological complexity in our guts, the so-called microbiome, where trillions of bacteria live. They influence how nutrition is absorbed, too. We're just beginning to understand their role in health conditions like obesity, inflammatory bowel disease, and allergies. We started this lecture talking about evolution and adaptation, and I want to return to that. Through almost all of human history, food was scarce. The hunting and gathering and then farming of food took up almost all of our ancestors' days. It is only in modern times that food has become plentiful, and even now, only in some parts of the world. It's only in the last 50 years or so that in many places food is so cheap and so plentiful that it's become as much a recreation as a source of nutrition, with pre-processed and packaged foods dominating our intake. At the same time, we no longer have to work the fields, and many of us can go days without exerting any kind of sustained physical effort. That's the huge ecologic change that we're confronting in the modern, developed world. And so far, we're not adapting our lifestyle fast enough to keep up with these changes. That's why about 1 in 3 of us in the United States are obese, and why so many of us will have shortened, sicker lives caused by, of all things, overnutrition. The other modern change that's contributing to obesity is screen time, the ever-increasing use of computers, cell phones, and television by adults and children. Over 70% of American children exceed the recommended screen time guideline of 2 hours a day, and that time in front of an electronic device has replaced active play and sports in many families. Most children now don't even get an hour of active play each day. Parents need to start reversing this trend by setting a good example and getting their children outside and away from the screens. There is some good news, though. The rate of obesity in children has leveled off over the last several years, perhaps in part because of better education and by parents and doctors taking a more active role in prevention. And we know that increased exercise, even if it doesn't lead to weight loss, does improve a lot of the functional consequences of obesity, like preventing diabetes, hypertension, and heart disease. Though there aren't really any good drugs out there to prevent or treat obesity, we have surgical options that can improve the lives and health of selected patients who've been unsuccessful with other weight loss strategies. We're not going to bring that up with Chaz today. We'll start simple and start small, and we'll continue to work with Chaz and his family to improve both his headaches and his overall health. In pediatrics, most of our patients are healthy. Kids, most of them, are born well and stay well. They do get sick, a lot of colds and coughs and viral illnesses, but at least in the developed world, these typically cause usually just a few days of misery followed by a rapid return to running and playing and getting back to school. It might not seem minor to a parent up in the middle of the night with a vomiting or feverish child, but most of the time, kids bounce back quickly, except when they don't. Though they're by and large healthy and strong, children are vulnerable. Their immune systems may not be fully prepared to defend them, especially if they haven't had all of their vaccines yet. They're often essentially showered with infectious organisms in schools and daycares. And the younger ones can't even talk yet, so they cannot tell us exactly what's going wrong. An especially vulnerable period occurs in newborns who have little protection from infection and are undergoing huge changes in physiology as they adapt to life outside of the womb. We have a saying in pediatrics, never trust a newborn. When things go wrong, they can go very wrong, very quickly. I'm going to present 2 Grand Rounds patients today, and we'll go through them a little more quickly than usual. The point today isn't as much to focus on making the correct final diagnosis, but to give you some experience learning one of the most critical skills every practitioner of pediatric care needs to have. How do you tell a genuinely scary sick child from a child that's going to be okay? Those except when they don't kids, the ones who need urgent intervention very quickly, those are the children we never want to miss. It's a needle in a haystack, those very sick kids, but if you pay attention, those needles glimmer and shine and give you plenty of clues that something is wrong. Our first patient is Chloe, a 6-day-old newborn who's coming in today for a routine recheck. She's the first child of a young couple and was born after an uneventful, normal pregnancy. There had been no abnormal screening tests or ultrasounds, and the delivery and hospital stay had been routine. Mom is exclusively breastfeeding, and the family was told to come in to see us a few days after leaving the hospital for a recheck visit. This first recheck is a very important visit. Most families stay 2 or 3 days in the hospital after birth, and typically that's not enough time for mom's milk to come in. We expect babies to lose weight at first and go home from the hospital still losing weight. But by day 4 or so of life, a baby's weight should hit the bottom and start climbing back up. The most important thing to check at this visit is whether or not a newborn is getting enough to eat. It's also an important time to check a baby's color. Are they getting too jaundiced? And overall strength and tone and breathing. Today, mom and dad look tired, but they say they have no worries. Chloe seems to be nursing okay, and they say she really almost never cries or makes a peep. They say she's a quiet, content little baby. Let's get a look at her. First, we'll glance at her weight. Chloe weighed 7 pounds at birth, and at hospital discharge 3 days ago, she weighed 6 pounds, 10 ounces. Today, 3 days after that, she's lost more weight, down to 6 pounds, 6 ounces. That's not a disaster, but it does make us concerned. By now, she should be gaining back and heading back towards birth weight. Maybe she's not nursing quite as well as she should. Her other vital signs: temperature 98.2, pulse 188, respirations 72 breaths a minute. Remember, I said that picking out those really sick kids can seem like looking for a needle in a haystack. The vast majority of newborns and almost all children overall are perfectly well. Even when they're sick, they're not that sick. But I also said that the needles, those clues, shine and glimmer and stick out if you're paying attention. Here's the first pay attention moment of this case. Those vital signs are very abnormal. Always pay attention to vital signs. They're called vital for a reason. Normal newborn vital signs look different from those of other children and adults. Their respiratory rates are faster, their pulses are faster, and their blood pressures are lower. Having said that, Chloe's vitals are still very abnormal, even for a newborn. Her respiratory rate should be less than 60, and her pulse should be less than 150. Instead, they're 72 and 188. Now, if a baby is screaming and upset, you'll get all kinds of crazy numbers that don't mean much. But Chloe is calm. Something is wrong here. We need to get more information fast. Although we often skip blood pressures in babies and children under 3, in a situation like this, with a baby who's not right, we need that blood pressure measurement. We'd also like a pulse ox, that's short for pulse oximeter, to check the oxygen saturation in the blood. That pulse ox has become such a common measurement that it's sometimes referred to as a 5th vital sign. While our nurse is getting those extra vitals for us, let's examine Chloe. She's up on the table on a receiving blanket. Her color is not good. She looks kind of gray, and her extremities feel cool. When we press on the skin on her heel, pressing out the pink color of the blood, the color doesn't return quickly. The skin just stays pale. That's called a delayed capillary refill, and it's a sign of poor circulation. Her pulses, when we feel them at the tops of her legs, are weak. We're not sure we can feel them at all. Putting a hand on her chest, her heart is beating fast and kind of bounding against our hands, very hard, what we call hyperdynamic. And her breathing, you can tell it's fast and shallow, like she's panting. Are you getting worried? I sure am. These vital signs and the physical findings all mean that this is a critically ill baby, one nearing circulatory collapse. Her heart is beating like crazy, but she still has poor circulation with fast, thready pulses and poor color. We do need to figure out why, but first things first, we'd better do what we can to stabilize Chloe and get her the help she needs. Quickly, in this order, this is what we do. We start with what are known as the ABCs, which stands for airway, breathing, and circulation. These are the initial steps for emergency assessment and intervention for any critically ill child. A, airway, we make sure that Chloe's airway is open. And if it weren't, we take whatever steps needed to open it up. B, breathing. We make sure that Chloe is breathing. And again, if she wasn't, we'd start breathing for her. In a medical office, we wouldn't use direct mouth-to-mouth resuscitation. We'd use a device called a bag mask ventilator. But the idea is the same. If a child is so ill that they're not making an effective effort to breathe, you have to breathe for them. Chloe is breathing rapidly, and you can see her chest rising and falling. So air is getting in and out. C, circulation. You first make sure that the heart is beating, and if it isn't, you start to give chest compressions. In a newborn, chest compressions are done using just a few fingers on the chest, pushing down and letting up. Chloe's heart is beating. We don't need compressions, but we know her circulation is poor. What we do next is arrange for more help. We don't have the equipment or resources here in the office to help further with circulation. So we do the next best thing. After a brief explanation to mom and dad, we call for an ambulance to get Chloe to the nearby children's hospital as soon as possible. While waiting, we'll put an oxygen mask on Chloe. That may not fix her circulatory problem, but it may help her deliver more oxygen to her tissues. You've also got the news now from your nurses about those vital signs. Her blood pressure, measured in her right leg, is 40/22. That's very low. And her pulse ox at the end of her right big toe is 85%. That should be at least 90%. It's a bit of a scramble here. Your nurses are checking things, you're hovering over Chloe, and of course her parents are terrified. You'll try to keep your cool and explain to her parents that Chloe is breathing and her heart is beating strong, but her circulation isn't good. It's really important that she get emergency care with medications and with access to high-tech care right away. And there's an excellent children's hospital right nearby that you know can help her the best. You apologize and say you don't have all of the answers yet, but that even though the ambulance will be transporting the family, you'll stay in touch to help. You'll have your staff be sure to get mom and dad's cell numbers, since it can be hard to reach families in a busy emergency department. Within just a few minutes, the ambulance crew is there and they recheck the vitals and they take off with Chloe and her mom. There wasn't quite enough room for Dad, but he'll follow behind in their car. You remind him to drive safely and that Chloe is in good hands. The staff and you are shaken up. It will take a few minutes to let everyone catch their breaths, but there are more patients waiting to be seen. There are always more patients waiting to be seen in a pediatric office, and they're not going to be especially happy about the wait. Still, to wrap up this first case, what happened to Chloe? She presented with markedly poor circulation at 6 days of life, with a high pulse and respiratory rate, poor oxygenation, and poor color and pulses. She had also presumably been feeding poorly for at least a few days. Remember, her weight wasn't good. So maybe this wasn't a super sudden thing, but rather something that developed over a few days. Remember, I said, never trust a newborn, and Chloe's case illustrates exactly why. She had had a normal gestation, normal echoes, normal everything, but she still got really, really sick. One of the reasons this can happen is that in the immediate period after birth, newborn babies have to undergo profound changes in their circulation, and if that doesn't work right, there is grave trouble. Add to that scenario exhausted and inexperienced parents who might not recognize early signs of problems. That's why the newborn period can be such a vulnerable time. Before birth, a baby's circulation is very different. Almost no blood circulates through the lungs. Unborn babies don't breathe or depend on their lungs for oxygen. Instead, almost all of the blood exiting the heart ends up flowing through the umbilical cord to get oxygen and nutrients from the placenta. Once that cord is clamped shut at birth, the placental circulation stops completely. All of that blood has to be shunted back through the lungs. There are multiple changes that take place to make this process work. One of them, and this is the one that turned out to be the most important for Chloe, is the closure of a tube that before birth connected the pulmonary artery to the aorta. The tube is called the ductus arteriosus, though we often say in shorthand just the ductus. Before birth, that tube lets blood that had been heading to the lungs go instead to the aorta, to the baby's circulation, and down towards the umbilical vessels. After birth, it closes so that blood circulates through the lungs. But it turns out that something went wrong in the development of Chloe's circulation. This was confirmed by an echocardiogram done in the emergency department. Chloe had a congenital malformation of her aorta called a coarctation, which is basically a blockage of flow. While her ductus was open, blood could bypass this blockage by going through the ductus. But as it closed after birth, blood could not get to her body's circulation. That's why her heart was beating so strong and fast, yet her pulses and blood pressure were weak. As her ductus started to shut, less and less blood could get through her aorta, and if it had shut completely, Chloe would not have survived. But with prompt recognition and therapy, when her ductus started to close, Chloe did well. In the emergency department, medication was quickly administered that reopened the ductus, reestablishing flow through her aorta. Then, once she was stabilized, a surgical procedure was performed to open up the blockage. Chloe, after a few scary weeks, did very well and isn't expected to have any long-lasting problems. Prompt recognition that her abnormal vitals and appearance meant something very bad allowed her to quickly get the treatment she needed to survive. By the way, a coarct isn't the only problem that can look like this, presenting with a very ill newborn. Other heart diseases, infections, and metabolic problems can look identical. In this kind of presentation, the most important steps are recognizing that something is very wrong and getting the baby to where she can get the evaluation and care she needs. That comes before establishing a definitive diagnosis. And to reassure those of you with very young children or expecting babies right now, presentations like this with a critical heart illness that develops over the days following birth, they're much rarer now. The current standard of care in newborn nurseries in the United States and many other countries now includes a screening test for these kinds of conditions so they can be caught early before a baby is sent home. While no screening test is 100% sensitive, we know with screenings that we can catch most of these kids before they become as sick as Chloe. Our first patient was very ill at the first visit, but in pediatrics especially, you have to remember that our patients are moving targets. Sometimes the story changes, and you have to keep an open mind that your initial diagnosis may no longer be correct and may no longer reflect the most serious problem. Our second patient today is Vinod, a 9-year-old boy who has told you that he goes by Vinny. He was first brought to your office for this illness 1 week ago with a fever and cough. He also, you recall, brought with him a large plastic dinosaur that could shoot missiles from its mouth. He was very excited to show that to you. At that visit, he had been sick for about 1 day and had a fever of 101.1 degrees. His vital signs were normal, and he looked comfortable and well with no trouble breathing. He was diagnosed with a viral infection and told to contact you or come back if he wasn't getting better in a few days. And in fact, that's what happened. 2 days later, Vinny was brought back because his fever was higher and his cough had gotten worse. That day, his temperature was 102.7 degrees, and he was breathing a little fast with a respiratory rate of 36. That's high for this age. He didn't bring his missile-launching dinosaur. He said he left that at home, and he didn't seem quite as happy to see you this second time. Though his examination did not reveal a specific diagnosis, you were worried about the fast breathing, so he was sent for a chest x-ray. This revealed a mild small pneumonia, an area of infection in the lung. Vinny was started on an appropriate oral antibiotic for outpatient care of pneumonia and told to call you if not getting better within a few days. He was also told to return for a recheck in a few weeks to make sure that all was well. But Unfortunately, all didn't go well. 2 days later, his parents called on the phone that he didn't seem better. Well, they said his fever was better. It hadn't been over 100, but he wasn't active. He just wanted to lie around, and he said his chest hurt, and he didn't want to eat. You told his parents, please bring him in. We'd better get a look at him. Well, they weren't very happy about that. They'd already been to see you twice, but you spoke with them and explained that his getting sicker was concerning and not what you expected. You'd better get a look at him. Tomorrow, Mom asked. Can I just bring him tomorrow? No, you said. Bring him in now. I need to see him to make sure he's okay. So this is Vinny's third visit to your office within a week. He's already been diagnosed by X-ray with pneumonia, and he's already on antibiotics. Looking back through his chart, Vinny's been a healthy young man with no prior history of pneumonia or really any other significant problems. His general appearance today, first, he's not really very interested in talking at all and seems kind of quiet and withdrawn. His vital signs today include a temperature of 99.2 degrees, pulse 146, respirations 20 per minute, and blood pressure normal. That temperature, 99.2, Mom asks if that's a low-grade fever, and you tell her no, that's normal. It is a myth that 98.6 is the normal temperature. In fact, it's the middle of a range of normal. Sometimes people are a little higher or lower within that range, and that's okay. The upper limit of normal body temperature is usually considered 100.4 degrees. So at least right now, Vinny does not have a fever. His respiratory rate, too, that's normal. That weighs against a worsening pneumonia. Most children with pneumonia breathe fast. But that pulse, 146, that is really high, and especially so when you look back to see that 2 days ago, even while he had a fever, his pulse was 98 beats per minute. What can cause a fast pulse? Many things, and a lot of them medically are very important to recognize. Fear or anxiety will raise your pulse, though Vinny certainly doesn't seem anxious or agitated. He's kind of quiet, really. There's no dinosaur discussion today at all. A fever will also raise the pulse by about 10 beats per minute for each degree of elevation, but Vinny has no fever today. Anything that interferes with normal circulation will raise the pulse too. We saw that in our first patient today, Chloe. Her heart was unable to push blood past a blockage, so it compensated by trying to beat faster. Likewise, things like dehydration will raise the heart rate, as will some medications or anemia, that is, not having enough red blood cells to deliver oxygen to the tissues. There can also be primary disturbances in the heart rhythm, the way the heart beats, although that's unusual in children. Vinny's heart rate really is quite fast, and we'd better find an explanation for that. On the exam, Vinny does not look great. He seems tired, and his color, especially on his lips and face, looks pale. His lungs sound clear. You don't hear any abnormal noises, and he seems to be breathing easily. His cough, his parents mentioned this, has actually gotten better. The remainder of the exam is normal. One thought we had was dehydration. Anyone with fever can get dehydrated because that extra heat causes more fluid loss in the breath and from the skin. Vinny can't remember the last time he urinated, which itself is not unusual in a 9-year-old, so you ask him to pee in a cup as a way to see if he's dehydrated. We can quickly test urine in our office to see how concentrated it is, and very concentrated urine correlates well in children with dehydration. And that's when you get a surprise. The urine itself isn't concentrated, so he's probably not dehydrated, but it's a brownish color, like the color of Coca-Cola. Yeah, says Vinny, it's been like that. His mom is upset with him. Vinny, why didn't you tell me? That's another thing about pediatrics. Even our patients old enough to talk might not speak up to tell us something that we need to know. That brown color in the urine, there aren't a lot of things that do that. The main one we're thinking about is called hemolysis, a condition where red blood cells in the blood burst, releasing their hemoglobin and other proteins to float around in the blood. When this happens, the hemoglobin appears brown in the urine. That loss of red blood cells from hemolysis can cause anemia and decrease the blood's ability to deliver oxygen. Less oxygen delivery leads to a compensatory increase in heart rate, so that might explain what's going on with Vinny. We next measure quickly now in the office a finger prick little sample of blood to see if Vinny is indeed anemic, and he certainly is. He has a hemoglobin of 6 instead of the normal 11 or 12. With that decreased hemoglobin, he certainly will have poor energy, and he'll also have an impaired ability to fight off infections. You head back in to discuss this with the family, and what you see isn't encouraging. Vinny, who you thought might have been a little tired, is now lying down and looks worse. He's fallen asleep, which is very unusual for a 9-year-old at the doctor's office. You check a pulse, and it's even faster. And more ominously, you notice that he's now developing purplish bruises on his legs and belly. Those purple bruises, especially in a child who you know has a low red blood cell count, probably indicate a problem with Vinny's platelets, the clot-forming cells of the blood. Vinny is getting sicker right in front of you, and the diagnosis of pneumonia now seems to be the least of his problems. Vinny's blood oxygenation on his pulse ox is normal, and repeat vital signs look okay other than that fast heart rate. Still, you're thinking about him being so sleepy and what that means. Maybe he just hasn't gotten enough sleep, or maybe he's wiped out from fighting off the infection. These could be true, but the overall picture here suggests that Vinny may be slipping into shock, which requires urgent intervention. Shock is a physiologic state where the circulation is inadequate to supply the body's tissues with oxygen and nutrients. There are many pathways to shock, though in the end, the final picture looks the same. Shock can be caused by dehydration, by not having enough fluid in the body, or by the heart being sick and unable to pump. Or, as with our first patient, Chloe, it can be caused by a blockage to blood flow out of the heart. With Vinny, you're especially worried that this could be evolving septic shock caused by overwhelming infection. In septic shock, the inflammatory reaction to a serious infection leads to the leakage of fluids out of the circulation into the tissues, which leaves less blood to circulate. Oxygen delivery is impaired, and eventually the heart function itself deteriorates. It's critical to recognize, especially the early symptoms of shock, so treatment can begin as soon as possible. We've already gone over many of these symptoms, including a fast heart rate and low blood pressure, poor pulses, and a slow capillary refill. But one of the most important signs to look out for is a depressed sensorium, that is, acting sleepy. Vinny's sleepiness in the setting of a known infection, looking pale, being anemic, and these new bruises, all of that suggests the picture of evolving septic shock. And we need to, well, stop talking and take action. ABC's first, and oxygen, and 911 is called. On the way to the hospital, an IV is placed and fluids pushed. Giving fluids is almost always the first treatment for shock. Labs are drawn, and IV antibiotics are given, and the chest X-ray is repeated. What they found in the emergency department was that the X-ray itself really didn't look any worse, but his lab showed very low red cell and platelet counts. And something else too, his kidneys had shut down, putting Vinny in what's called acute kidney or acute renal failure. I said at the beginning that children are usually healthy, and they usually stay healthy. And even when they get sick, they usually bounce back quickly, except when they don't. Vinny started with a little fever and cough, then developed pneumonia, and then presented to our office again with what seemed to be septic shock. Once the story continued to unfold, it turned out that he wasn't septic at all. He had instead developed a condition called hemolytic uremic syndrome, the uremic here referring to increased urea in the blood. That's a sign of kidney failure. This is a rare but well-known complication of some kinds of pneumonias, but also gut infections with bacteria like E. coli, often associated with consuming contaminated meat or produce. Vinny ended up with a prolonged and rocky hospital course requiring multiple transfusions and advanced support in the ICU. He required dialysis, a medical procedure to filter the blood when the kidneys have shut down. This can essentially replace kidney function, but it is not a good long-term solution for children or adults, really, but sometimes there aren't other good options. About a year later, Vinny received a kidney transplant with his father as the kidney donor. All of this started with a bit of fever and cough. Of course, most fevers and coughs do not turn into this kind of nightmare. That's the haystack. The thousands of children like Vinny who had a viral cold or a mild pneumonia who never require further care. But there were some important steps we took that, while they didn't prevent the complications, at least prevented things from becoming even worse. Rechecking a patient, looking them over again when they're not improving, that's crucial, even when parents don't want to come back. Medicine isn't an exact science, and sometimes patients take an unexpected turn. We need to be humble enough to revisit what's going on and reconsider our diagnosis. That doesn't mean that we necessarily did anything wrong the first time, but as an illness develops, the picture changes and more clues can appear. That's when our diagnosis and treatment decisions have to change too. At every step, we also let the family know when to return or when to contact us if things aren't going well. Every plan needs to be clear, and every plan A also has to have a plan B. How long should it take for the child to improve? And what should the family do if a child isn't getting better? Next up, we'll meet some patients at scheduled routine visits, patients coming in for well checks. So they're supposed to be healthy, right? Of course they are, unless, of course, they're not. Let's keep our eyes and ears open and look out for those clues. See you next time. So far, in our Grand Rounds Pediatrics course, we've been concentrating on sick patients, children brought in to see us for a specific medical concern, like a fever, cough, or poor growth. Today, we're going to cover some examples of another kind of pediatric encounter, the checkup. These visits aren't meant to focus on a symptom or a known problem. They're more of an overview of what's been going on to make sure nothing has slipped through the cracks. In pediatrics, we'll use this time to review growth and development, both physical and mental, including learning, communication, and social skills. There are sometimes scheduled screening tests, like checking the blood for low iron or high cholesterol, or screening for vision or hearing problems. Reviewing the chart will catch up on any problems from the last year or so and make sure they've been addressed. We'll also do a careful, complete exam and talk about what's called anticipatory guidance, instructions and tips for parents on what to expect next, what kinds of challenges might occur, and how to deal with them. We'll also make sure Junior is caught up on all recommended vaccines and, of course, save time for mom and dad's questions. That is a lot of material, and parents can help get the most out of their kids' checkups by being prepared and focused. While it's reasonable to bring a list of questions and concerns, it's not a good idea to turn a checkup into a sick visit. In other words, if you've got a significant health worry that's going to take time to untangle, don't save it up for the next checkup. There just won't be enough time, and what may end up happening is that you'll get a rushed checkup along with a rushed evaluation of your health concern, and that's not the best way to help your child. Checkups should be checkups. If you're worried that your child has a significant health problem, go see your doctor for that and save the checkup for another time. Okay, we've got our checkups waiting. First is Evan, a 4-month-old infant. You'll start by reviewing the chart, seeing if there have been any past health concerns that we need to review. There's only one, spitting up, which Evan has been doing for the last few months. He hasn't been fussy, and he has been gaining weight well. So Evan is said to be a so-called happy spitter. That's a common pediatric term, and it's meant to reassure parents that spitting isn't usually anything to worry about, especially if it's not causing any pain. Evan has transitioned from breast to bottle feeding. Mom says she had to go back to work, and bottle feeding worked best. We also review some developmental milestones to make sure Evan is doing what a 4-month-old ought to do. And yes, he's smiling at everyone, babbling, reaching for a toy, and seems to recognize mom or dad from across the room. We take a look at Evan's growth percentiles, and he's really quite chunky. He's at the 98th percentile for weight, climbing up from the 40th to the 60th 2 months ago, and now he's much higher, while his length and head circumference have remained in the middle of the chart. That head circumference, it's a really important thing for us to track at checkups. An overly big head, or a head that's growing too fast, may be a sign of an important and treatable brain condition. And overly small heads worry us too. Now, sometimes it's just that mom and dad have big or small heads. You have to look at the context. And sometimes it's best to measure mom and dad's heads with a tape measure, comparing their head sizes with established norms for adults. As we go through the physical exam, we talk with mom and dad about their daily routine and about what Evan is like. One thing seems clear: he likes to eat and fusses when he doesn't get a bottle quickly. You ask, what else does he seem to like to do? Or what else do you do when he's bored or upset? His parents aren't sure of the answer to that. Since he's been spitting, his parents have been adding rice cereal to the bottle to thicken the formula. Evan's vitals are normal, and he's a smiling, happy, toothless baby. This is a really fun age, and 4-month-olds usually love meeting people and love the attention of a physical exam. At one point, though, he does get upset. Some babies just hate getting their ears examined, and Dad brings over a bottle to soothe him. Instead, you pick him up and talk to him, tickle his back, and he smiles. He seems to especially like your glasses, by the way, maybe the way they reflect the light. When he's close enough to your face, he tries to kind of bat or grab at them. So, what do you think? We didn't find anything specific on our actual physical exam, but the exam did give us a chance to get to know